This is a fun topic because it's a lot of pictures, and then at the end we'll have a little quiz and see who can get the right diagnosis. Anyways, the term pseudo-cellulitis, I don't think it's in the Oxford Dictionary, but it's a term that I've seen used the last few years. And basically it's any skin condition that is misdiagnosed as cellulitis. So all these other possible causes that are not really cellulitis. And basically it's all that's red is not infection. So we're going to go through how to differentiate real cellulitis from all this myriad of other possibilities. So next slide, please.
All right, Charlie, I'll take these ones. So this is a disclaimer, just letting you know that we do record these sessions and make them available via our Project Echo Nevada website. If you have any concerns about being on that recording, let us know, send us something through the chat box, and we can actually edit you out of anything that we post. And then another reminder here, if you do decide to present a patient case for us here today, please just don't disclose any protected health information, such as patient name, date of birth, occupation, those sorts of things. And then just one more here, our disclosure policy, just letting you know that our team has no relevant disclosures pertaining to the content here today, so we can provide you with CME credit.
So goals of this talk, I want to identify 3 negative outcomes from the misdiagnosis of cellulitis. Also then describe 3 key findings to help you make the correct diagnosis of cellulitis. And then identify 3 clinical findings that will point you away from cellulitis to alternative diagnoses, particularly Stasis Dermatitis. And recognize 5 other conditions besides Stasis Dermatitis that can cause a red leg. And remember, cellulitis is almost never bilateral. Next slide. So I'm going to present a case. So what are the negative consequences of misdiagnosing cellulitis? Say, oh, what's the big deal? Just wrong antibiotic. And there's obviously 3 big ones. One, you're putting somebody in the hospital, and most of the time, if it's not cellulitis, they don't need to be hospitalized. 2, we all know that Difficile Colitis is a unfortunately common complication in hospitals of antibiotics. And you can get these drug reactions like a Stevens-Johnson reaction. So it's not a free lunch when you misdiagnose cellulitis. Next. All right, so this is a case that we'll go back to, but just a standard case you probably see quite often. And this is a 62-year-old guy, history of usual comorbidities, diabetes, he's overweight, has heart failure. He's complaining of increasing bilateral low extremity swelling and a burning, itchy rash. Next. So he goes to his doctor, he sees his primary care physician. The doctor diagnoses him with bilateral leg cellulitis, gives him a 5-day outpatient course of Keflex, and he returns 5 days later, noting no improvement in his leg. So the doctor admits him to the hospital for intravenous antibiotics. In this picture of his leg, you can see bilateral redness, and on the left leg, the upper one, you can see some skin desquamation. So he hasn't responded to outpatient antibiotics with his bilateral cellulitis. Next slide, please. He gets admitted to the hospital. He has no fever. His white count's normal. He's given the standard IV Unison, Amstel back to him. His legs are elevated. He's given increasing diuretics, a low sodium diet. Over the next few hospital days, the leg swelling and redness both improve. Blood cultures are negative. And he's discharged home in another week of oral Augmentin, which is like the equivalent of a Unison in the pill form. He does well at home initially, but soon the bilateral leg swelling and redness recurs. Returns to the emergency room. They notice the bilateral red legs. They diagnose recurrent cellulitis, treatment failure of standard antibiotics, and so they put him on vancomycin for empiric cellulitis coverage. This is something we see all the time. So this is what's critical. So we're going to go over cellulitis versus pseudo-cellulitis. And so always keep these characteristics when you're going to be sure that you make a diagnosis of real cellulitis. Redness, warmth, tenderness, and swelling of the skin. It has to have a rapid progression and systemic symptoms much of the time with fever and chills and a white count. So redness, warmth, tenderness, and swelling of the skin with the white count, rapid progression, and the patient feeling poorly are really classic for cellulitis. Things that this does not apply to makes you want to think that you're maybe dealing with an alternative diagnosis of cellulitis. So a symmetric or diffusely scattered pattern in any condition other, it should be seen in other conditions than cellulitis, which is overwhelmingly unilateral with smooth, indistinct borders. So if you see symmetric, bilateral, diffusely scattered pattern, you might start thinking of anything other than regular cellulitis. But in a long-standing, slowly progressive course, bilateral involvement and a history of unsuccessful treatment with antibiotics are strong indicators of a condition other than cellulitis. Sounds like the patient we just presented. Next slide. So this is strep cellulitis. These are unequivocal cases. Remember, redness, warmth, swelling of the skin. But what's also classic about cellulitis is while you get swelling of the leg, if you close your eyes, you cannot feel the edges of the cellulitis. Okay, the skin may be swollen and may be tender, but you should not be able to demarcate the edge of cellulitis. And it also is, you have all these findings, but you also don't have bullae, you don't have scales, you don't have desquamating skin or hyperpigmentation. So it's redness, warmth, swelling of the skin, often with a rapidly progressive course, fever, chills. Okay, so we have a classic case here. We see some swelling, but if you could feel the edge, you would not be able to feel the edge with your finger, but you would feel some edema. Okay, there's no other skin findings. Next picture. So the key, so these are two more pictures of cellulitis. Again, a red spreading rash with none of the characteristics of stasis. Again, we see edema, we see warmth, I mean, it probably is warmth, rapid spreading, and you have swelling, but again, you cannot demarcate with your eyes closed the edges of the rash, and you don't have any of the other hyperpigmentation or other changes. So this is 3 classic cases of strep cellulitis. There's no question about it. Next slide. So pseudo-cellulitis. This patient that we just talked about has stasis dermatitis. He has bilateral involvement. It's itching, not burning, not tender. So itching, burning, skin peeling, lack of fever, normal white count. So this is a slow disease. This is not a rapidly progressive disease. It's bilateral. There's no burning. There's no, the edges are, you can feel the edges. There's a lack of fever and normal white count. So true bacterial cellulitis presents with a painful rash, a single unilateral focus of infection with ill-defined borders, little scaling and enlarging quickly. So this patient also, we saw he took Keflex, which would have taken care of strep cellulitis, and he was given IV units. Again, he relapsed when he got up, started walking around, and the rash returned. And it was bilateral with desquamation. So this was stasis dermatitis. So let's look at some pictures of stasis dermatitis. So stasis dermatitis, before we go on, is the most common cause of pseudocellulitis. The inciting factor is chronic venous insufficiency, leads to edema, extravasation of red cells, decreased tissue oxygenation, and microvascular changes and skin changes. And it's a very common problem. Next. So the physical exam in stasis dermatitis, the rash spreads slowly over days to weeks. This other patient that we first presented, the rash really didn't really change over days to weeks, except when he elevated it and he kept off his feet. There should be blisters and bullae, oftentimes seen in stasis dermatitis, which we don't see in cellulitis. You can see distended veins and varicosities. You can see signs of chronicity, scales, plaques, ulcerations, and crusting. All right, so none of these findings should apply to strep cellulitis. So if you see any of these things, particularly with a rash that slowly spreads instead of over hours to days, it takes weeks to spread. Next slide. So here's stasis dermatitis. What we notice, bilateral, okay? We see sort of patchy rashes. We see that if you close your eyes, you can definitely feel the edges of these rash. You can feel where the rash starts from the normal skin. You see that there's peeling, scaling, bilateral, and not that diffuse redness present in cellulitis. So these are 3 patients that were hospitalized for bilateral cellulitis, but again, they have stasis dermatitis. The bilateral nature, the scaling, the induration, the hyperpigmentation are all characteristics of stasis dermatitis. And I assume they would have had no fever. They probably have some burning, tenderness, and no systemic complaints. Next. Again, this is very severe cases of stasis dermatitis where you're getting hyperpigmentation, the skin is bound down, indurated edges. This is people that were admitted to the hospital. So the one on the right here that's circled by red, it's one leg, but again, you can feel the edges, it's hyperpigmented, and it seems like it's just sort of stuck in place, right? So this is, this is a very hyperpigmented, the change in the skin color. You don't see change in skin color, you just see the redness with cellulitis. So these are two cases of stasis dermatitis that were both hospitalized. Next. Again, these are severe stasis dermatitis. The picture on the left, you can see vascular insufficiency, you see plaque development, you see hyperpigmentation. Again, the skin is taut and hard and not like the soft red swelling you see in cellulitis. And severe stasis dermatitis, you can see blisters, desquamating skin, and eschar formation. Again, these are patients who were admitted for severe cellulitis, bilateral cellulitis, but this is characteristic of stasis. This is a woman who was admitted, multiple admits for bilateral cellulitis. If you look at her initial presentation on the left, again, you see bilateral redness, you see bullseye formation, you see a little bit desquamation, and you see that the rash is not confluent, it's sort of patchy bilateral. And so this is another case of stasis dermatitis, not cellulitis. And after a few months, she got more induration, more hyperpigmentation, and more of a bound down appearance developed for this patient. Okay. Cole has to stop the video. Okay. So the therapy of stasis dermatitis. If you diagnose stasis dermatitis and begin proper therapy, the skin redness will resolve with treatment of the dermatitis without antibiotic therapy. The treatment is really using strong topical steroids, leg elevation, and compression stockings for milder or severe cases. And this will help a lot of the redness and the induration resolve. So there's no real role for antibiotics in these patients, but really identifying the disease and treating properly. Let's differentiate one more time, then we'll get a whole bunch of pictures. Cellulitis, oftentimes a history of trauma, lymphangitic streaking, unilateral, an acute episode, fever or chills possible, but not mandatory for diagnosis. Usually there's no scaling, blisters, or bullseye formation. There's a white count and it's tender. Stasis, however, oftentimes in the setting of varicose veins, the redness are often associated with scaling, blisters, eschars. It can be bilateral, it's chronic, recurring, there's no fever. You can feel the edges when you examine the patient, and oftentimes there's hyperpigmentation when it's a chronic problem.
Dr. Krasner, a question here from Dr.
Yes.
He's asking, can you describe a venous stasis dermatitis that becomes a cellulitis? That's the bulk of cellulitis admissions among veterans.
Well, definitely, what you can see is somebody who has chronic bilateral stasis, and then maybe they cut their skin and they get a whopping strep cellulitis on top of it. Okay, that definitely can see. But that rash, the strep cellulitis, will be a classic strep infection, rapid progressive, going up their leg, white count, fever. So you definitely can, stasis dermatitis can be complicated by a secondary infection. What do you do with bullseye? Probably, again, the elevation. I'll show you a picture later about bullous infection. Elevation, compression stockings, steroids, and that should help. It's really just stress on the skin with so much edema. Next slide.
All right, just one more question here from Dr. Levy.
Sure.
Any concerns with using steroids on venous stasis with skin breakdown, such as desquamation or ulcers?
Well, I don't think I'd put it on a open ulcer, but definitely on a closed skin lesion. I would do it. All right, so before we talk, look at some test questions. These are other possible of pseudo-cellulitis. So up in the left corner, what does anybody, what's the possibilities for that foot?
Gout.
Yes. So gout can be tricky, but usually you get a great history. You know, they wake up in the middle of the night, their toe is crazy, in pain. They have extreme tenderness of the metatarsal phalangeal joint, but you can get a white count and a fever associated with it. So, but it really is just the gout causing it. So I can understand giving that antibiotics, but the gout attacks I've seen can look exactly like cellulitis, but you know that the underlying cause is the gout, but it really isn't the cellulitis. It's just erythema. How about the right upper quadrant,
Eczema.
picture?
Atopic dermatitis.
Atopic dermatitis. Yeah, very good. How about the left lower picture?
Cellulitis.
DVT.
MRSA. MRSA.
So
you could be concerned about septic thrombophlebitis or thrombophlebitis.
Yeah, so that's a DVT. So again, you can be a bit fooled, but you know, you get severe tenderness, you'll do an ultrasound, the leg is swollen, and you'll diagnose a DVT. So again, it looks like a lymphatic spread of cellulitis, but usually it's significantly swollen more than just over that site. And you have a history of risk factors. So oftentimes an ultrasound will help differentiate that. And then the bottom right.
Lymphedema.
Yeah, exactly. So we have stasis, gout, DVT, atopic dermatitis, and lymphedema. Next slide. So this is just before we go into the quiz section. There's multiple articles like this, basically done by dermatologists. They always do retrospective studies because you can never get them to come into the hospital. But this is cause and consequences associated with misdiagnosed lower extremity cellulitis. And they reviewed almost 260 consecutive patients admitted to a hospital in Massachusetts with a diagnosis of lower extremity cellulitis. They reviewed the hospitalization and 30-day post-discharge analysis. They found 30% of these patients were misdiagnosed with cellulitis. And most of the reasons that they were misdiagnosed with the diagnoses they actually had, they did not need to be in the hospital. So the next slide. So in this case, of 79 cases in this article, vascular reasons were the majority: venous stasis dermatitis, like stasis dermatitis, venous stasis ulcers, heart failure, DVT, peripheral vascular disease, and a smattering of gout, contact dermatitis, and drug reaction. Okay, so about a third of all patients admitted with the diagnosis of lower extremity cellulitis, multiple studies, some show as much as 40 to 50% are misdiagnosed, and most don't need to be in the hospital for that diagnosis. Next. So summary of cellulitis diagnosis. It's rarely bilateral. Patients with cellulitis often have systemic symptoms such as fever and leukocytosis. A chronic or recurrent course, such as we saw with the case presentation patient, suggests a diagnosis other than cellulitis. Again, it was a slowly progressive rash that came and went with elevation, did not respond to antibiotics, was desquamating. He didn't have a white count, didn't have a fever, and he didn't have that tenderness, all pointed away from cellulitis and an alternative diagnosis. Particularly plaques of a bound down appearance or dark pigmentation point to a chronic disease rather than cellulitis. And this is the most common mimic of cellulitis. Next. Just in terms of antibiotic stewardship, you know, we have treatment guidelines, how to treat pneumonia, how to treat bacteremia, how to treat cellulitis, but the guidelines aren't worth squat if the diagnosis is wrong. You know, we have these beautiful flow sheets, so it's really important. You know, if 30 to 40% of these diagnoses are wrong, you know, we're lucky we have pictures in the media section where they take pictures of everything, which can be very helpful, or going to examine the patient before saying, oh, this is unison first for cellulitis. If you don't have the media pictures available, go and look at the patient. What are they treating? Is this really strep cellulitis, or is this stasis dermatitis that doesn't need antibiotics? Okay, so that's called handshake stewardship, where the antibiotic stewardship team walks around, sees patients who are prescribed antibiotics for quote cellulitis, and takes a look at the patient and makes suggestions. Okay. Also, somebody may be sick with strep cellulitis. which might be the right diagnosis. You don't need vancomycin to treat those kind of things. And oftentimes, we see people everybody who's sick getting vancomycin. And as an antibiotic stewardship person, you can go and say, we don't need MRSA coverage. We don't need anaerobic coverage. Let's just do like cefazolin or Unicin or something simple. So stewardship can play a very important role in the management of cellulitis. Next. All right, so what time is it? It's quiz time. And so I'd like you guys to take a look at the pictures and think for yourself and tell me what you see. So this was a patient who was just in the hospital last week, not responding to vancomycin. Anybody want to describe what they see and what they think their diagnosis is?
Stasis Dermatitis.
Yeah. What characteristics tell you?
Bilateral.
Yes.
Hyperpigmentation.
Yes.
Stasis Dermatitis, most likely.
Yes, for sure. And you see you can feel the edges of the tissue. You see blistering, eschars. So this is not a joke, though. These people are being readmitted over and over again for these kind of diagnoses. Their legs are elevated in the bed at the hospital for a few days. It gets better, and they get sent out, and it comes over and over again. So this patient needs, a good wound care nurse to steroid application, some compression stocking, and making the patient that doesn't need to come to the hospital. Next one. All right, so this patient woke up in the middle of the night with a painful great toe.
Gout.
Yeah.
Typical vacation, just and joint.
Doesn't need antibiotics. Yes, exactly. Again, but these patients can have a white count. They can have a fever from the gout. But again, you treat for the gout. Next. This is a patient who was admitted to the hospital, and he was put on IV Episil sulbactam Unicin, and he didn't respond to treatment. What's your diagnosis and what characteristics pointed out?
Has bulla, probably stasis dermatitis, bilateral involvement.
Right, and it's hyperpigmented. The edges are raised. Yes, there's some.
Yes, Suzanne, go ahead.
So, again.
No, it's okay.
Sorry.
Again, stasis dermatitis. None of the characteristics of, there's no warmth, there's no swelling of the skin, the edges are palpable, it's probably tender, and this has probably been going on for weeks to months.
Dr. Krasner, question from Dr. Bayan here. Is visually well demarcated rubor uniquely cellulitic?
So it should be red, but it should be hyperpigmented. It should be warm, tender, diffusely erythematous. But if you close your eyes, you shouldn't feel the edges, which you do in stasis dermatitis. You can also have redness with a severe infection like necrotizing fasciitis, but that's a different diagnosis. But it should be a diffuse red, rapidly progressive rash without any of the findings, the scaling, the hyperpigmentation, the blisters, the desquamation, and that will give you the diagnosis of cellulitis.
I have a question actually after all this is Suzanne. So we've seen some pretty amazing pictures here. Is it progressing to the extent that we're seeing in these photos because of misdiagnosis and not proper treatment? Or is it just that, there's just such a variety of severity?
I would say it's a variety of severity. But again, the patient I saw at my case presentation, just has some bilateral redness and desquamation. So it can be pretty mild. But the tip-off for him was that it's recurrent, it's not moving, he has the desquamation. And then you can get these other patients but I think what happens is they get admitted, they get their leg elevation, they get diuretics, they go home, it's looking better, and then it recurs. So they come in over and over again. A lot of these patients here have been hospitalized multiple times, and they get this superficial improvement, and then they come back. But these patients can have significant improvement, even if it looks as bad as this picture, with treatment. They just have to understand what's going on with it.
Hi, Mordecai here. One thing that I would add that Charlie mentioned is that this happens over a really long time. Like this would happen over weeks to months to years. And so getting that history is super important to understanding if you're thinking it's a cellulitis.
And also not responding to antibiotics, but just recurring and being bilateral. Next. All right, patient applying Neosporin to a bug bite.
Is this just a regular bacterial infection? I mean,
I would say the dermatitis.
Yeah. Yeah. So this again, this is a contact dermatitis. Again, you can see the edges. There's some desquamation. The edges are probably palpable. It doesn't move. And Neosporin is a classic thing for getting allergic reaction to. So again, this patient was hospitalized for cellulitis, but it was just contact dermatitis, and he needed just to be given some hydrocortisone to apply to it. But again, it's not that, if you remember those pictures of the cellulitis, the skin is smooth. There's some swelling. It's bright red, and you cannot feel the edges. This patient probably has no fever. So this is the patient we saw at the hospital. Next one. This is the patient we saw at the hospital last week. And she presented with a few-week history of bilateral swelling, redness, and ulcerations. So this is a more challenging case. She has bilateral stasis changes, but actually it got so severe that she probably developed what we call paniculitis, so like an infection. You can see these ulcerations. She had purulent drainage from these sites, so it got so severe that the fat underneath her in her legs got infected. So she actually had infected paniculitis as like from an ulcer that became infected from her Stasis Dermatitis. So she would probably need IV antibiotics, but she would also need, when this got under control, treatment for Stasis Dermatitis. She had developed an increasing heart failure, the swelling, and came in with these lesions. But she was in significant heart failure.
What would you have treated? What did you guys treat her with?
She got unison for these ulcerations and elevation. So, but again, it's bilateral, which tells you that it's Stasis Dermatitis, probably complicated by an infected ulcer. And you can see some of the desquamation of the skin. Okay, next. So painful leg 5 days after major surgery. This patient was also treated with IV antibiotics.
DVT?
Yes, DVT. Again, it's not a confluent rash. It's patchy rash. It's very painful. It's after surgery, so an ultrasound would have been ordered and DVT would have been ruled in. Acute onset of a unilateral rash.
cellulitis.
Beautiful. Right. Okay, so this patient looks like he has some lymphedema and bilateral lymphedema, and then they got scratched themselves and got an infection. So you can see significant swelling, you can see redness, but you don't see blistering, bullae, etc. And if you could feel on the slide, you would not be able to feel the edge of it. And there's no hyperpigmentation. So this is a patient with lymphedema who developed strep cellulitis. All right, so people do actually get strep cellulitis. And this is a patient at another local hospital who was admitted 3 times for persistent cellulitis. And this was just a few days ago.
Stasis dermatitis.
Yeah, so what? What findings point to stasis?
It's bilateral demarcation,
Yeah.
hyperpigmentation.
Yeah. And you can see desquamation of the guys of the foot on the left. The skin is peeling. You see hyperpigmentation. The edges are obviously palpable. People do this. I was admitted 3 times for persistent cellulitis. So he again needs good wound care, steroids, elevation, and compression stockings. I think that's it. Next slide. All right. So these pictures were either taken by me or donated by some of the pharmacists I work with. They're randomly found on Google, or this Dr. Noah Kraft, who I feel a kinship with, did a great video called Red Skin, What Can It Be and What Should I Do About It on YouTube in 2013. So it's really important when you look at your patients, is it just a strep cellulitis or is it a misdiagnosis? And we talked about the characteristics of stasis dermatitis, the slow progression, the fact that strep cellulitis can cause swelling of the legs, but with your eyes closed, you should not feel an edge, and you will with stasis dermatitis, the hyperpigmentation, the blistering, the induration, the lack of white count or fever, and oftentimes itchy rash. And as a lot of these pictures were just taken in the last week or two, so it's a very common admissions that we see in the hospital, and it's really step back next time you take a look at somebody. Is this really cellulitis or is this pseudo-cellulitis?
Question here from Dr. Planskaya. Can one get just bullae without erythema with contact dermatitis, or is it something else like pemphigus? Sorry, I probably butchered that.
Yeah. Contact dermatitis is usually you have the eczematous appearance with the bullae on top of it. I've never just seen bullae by itself with a normal skin underneath it. So I would be thinking of some of those pemphigoid and all those kind of blistering conditions. But usually it obviously can get really bad, contact dermatitis. I've seen ones, people thought it was a neck fash, but it was just a neosporin reaction. So definitely you can get blisters, but it also should be in the setting of the abnormal skin along with it. Jessica, you have any thoughts?
In general, or about
how much the overuse of vancomycin for cellulitis?
Absolutely, and I would add one of the common mistakes people make with the treatment of cellulitis is using doxycycline for strep cellulitis,
right,
when it happens to be a real cellulitis. And so a strep cellulitis will not respond to doxy because doxy has very poor activity against group B strep and group A strep. So just something to keep in mind.
And Bactrim too.
Yes. Bactrim is a little bit more controversial. I have seen several failures with Bactrim and strep cellulitis, but some people will swear by it. I always I avoid Bactrim whenever possible for a strep cellulitis due to my personal experience with it.
Yeah, we've seen people admitted with real cellulitis who are on doxy or Bactrim as an outpatient. And if you're not sure if it's staph or strep, amoxicillin plus Bactrim or amoxi and doxy are good combinations.
I'm Mordechai here. Do you guys, I remember when I was in residency, some people would tell me that if you had Staph aureus, you would most likely get like an abscess rather than a cellulitis, and strep would be more likely to be a cellulitis or something worse. Do you guys have any comments on that as far as abscess versus just cellulitis and what it might be?
I agree 100% with what you said. People, they'll give vancomycin for a strep cellulitis. Staph does not produce a diffuse cellulitis; it produces a localized abscess with overlying erythema. You can see sometimes people will have a deep abscess with staph, and it's red on top, but it'll be a localized redness and there'll be induration pointing to underlying abscess. So I don't believe that staph by itself causes diffuse cellulitis. It just doesn't. And that's a very good point. And so, we see people getting, for strep cellulitis, you don't need, Vanco. You shouldn't use Vanco. It should be, cefazolin, penicillin, ampicillin, something that just covers strep.
I would agree with Dr. Krasner 100%. I think the only exception would be in a severely neutropenic patient who may not have the white cells to produce some of that purulence that you see with abscess. But otherwise, abscess, you should be thinking staph for sure.
Caleb Borko here, Dr. Krasner. Quick question for some of those folks with chronic venous stasis. They're getting ulcers and are at risk for potentially that being a port of infection. How do you feel about doing topical antibiotic creams while you get those ulcers healed up?
Well, I think something like Silvadene ointment could be real helpful. It's an antibacterial activity. So I think Silvadene cream could be helpful. Silver alginate can be helpful just to reduce the risk of infection. So I definitely think those are reasonable approaches to it for sure, depending if it's dry or wet. But silver calcium alginate and zinc, silver sulfadine is also a good option. So I think that's very good.
Thank you.
Dr. Krasner, do you ever, in patients that truly get recurrent cellulitis, do you ever do chronic suppressive therapy with? Yeah,
that's like sometimes you get women who had a mastectomy and their arm continues, they get recurrent cellulitis because of the lymphedema, or you have very large patients who have autonomic changes. They have dry skin and cracked skin. Those are patients who definitely are at risk for recurrent cellulitis. And so in those kind of patients, I really give a lot of education about, after you take your shower, applying, like Vaseline cream, Eucerin, things like that, so you get that dryness away. And those patients, I've had patients with recurrent group E strep bacteremia. I'll put them on amoxicillin while they're trying to take care of themselves and get it better. But amoxicillin, there's no resistance to the penicillin. So I think penicillin or amoxicillin could be very effective for suppression. The New England Journal a few years ago had a nice study showing that it reduced the recurrent cellulitis about 50%. But as soon as you stopped it, they recur, unless you deal with the dry flake skin, which is very common in diabetic patients. And that's really important, especially if they've lost a toe or something before, because those patients get a bad infection, they're going to lose their leg. So be very aggressive in skin care, and using those antibiotics like amoxicillin or penicillin for prophylaxis is a good step, because the next step in those kind of patients, they can get a BKA or some other problem. So I'm an advocate of that kind of care.